Hi, my name is George, and today I'll be doing a presentation on PCSK9 inhibitors in treatment of hypercholesterolmia. So, as the name stands, hypercholesterolmia means that you have excessive cholesterol in your body, and they're usually bad cholesterol, known as low-density lipoproteins. I'll talk about these more in the next few slides and the introduction of monoclonal antibodies to reduce LDL concentration as well. I'll talk about how the physiology of the heart works. So initially, action potential is conducted from the SA node to the AV node. At the same time, the action potential spread throughout the atria, so the whole atria gets contraction, depolarized, and just before the AV node conducts to the bundle of his, there's a delay. This is to ensure that all the blood from the atria have gone from the atria to the ventricle, and then before the ventricular contracts and the atria relax. So at this point of time, the action potential from the SA node to the AV node and then to the bundle of His, and then to the Purkinje fibers. This whole process will be known as the PQRS wave. However, after the action potential has spread through the Purkinje fibers and it repolarizes back the heart, that will be known as your ST wave. And this process will continue over and over again as long as your heart keeps beating. This I'll talk about membrane potential. So initially you have a very resting state of negative 60 millivolts, and then when you want to increase your resting temperature, resting membrane potential to the threshold value. So you increase the non-specific, you open the non-specific cation channels to allow the influx of cations from extracellular to intracellular, such as sodium, potassium, calcium. Everything that's in your body that's classified as cations will enter the intracellular to bring it to the threshold level. And then this closes the non-specific cation channel and opens the calcium channel. It allows the influx of calcium extracellular to intracellular and then increase the membrane potential. And after a while, when it gets depolarized, the potassium channel opens and rush out from the intracellular to extracellular. So the membrane potential goes back down to its resting state. And this cycle will begin again when it goes back to the first loop. So every time your heart beats, you'll be the resting potential threshold up, depolarized down. This is one heartbeat, and then goes on 2, 3, 4, so on and so forth. As long as your heart keeps beating, you produce that curve. So as you can see, how does cardiovascular disease occur? It's through spontaneous coronary artery dissection, known as SCAD. This is because of the tear in the artery wall, and the tear is usually because of these muscles. These muscles, they help to contract or relax the blood vessels. And as you age, these muscles kind of loses its function, so it spontaneously tear because of wear and tear as well. Old age, you can't function properly, and then this tear allows the accumulation of fat and cholesterol into your body. So you can see in the magnified version, you have these yellow pigments that line the blood vessel, and these are all your oxidized low-density lipoprotein, calcium, cholesterol, fat, etc., etc., which is pretty dangerous and yucky. And they kind of narrow your arteries, so blood can't pass through the blood vessel, and this makes yourself prone to stroke. There's also other factors that include irregular heart rhythm, such as the blockage from the blockage on the AV node to the bundle of His. This is because there might be tissues that grow in your heart, and they can't conduct the action potential properly, like they cannot detect. So you kind of have this third degree block and then this irregular heartbeat of PRT wave. So I'll talk about PCSK9. So what's PCSK9? PCSK9 is an enzyme protein which is in the gene of chromosome. This is in the gene of humans in chromosome 1, and it binds spontaneously to the low density lipoprotein receptor known as LDLR in the hepatocytes or liver cell. This low density lipoprotein are usually known as lipoprotein A or apolipoprotein B 100, which I will talk about in the next few slides. So this enzyme PCSK9 kind of spontaneously bind to the receptor, and then when this lipoprotein floats, then oops, I got it. It kind of internalized to form an endosome. So this enzyme that's attached here, this lipoprotein and this receptor kind of form an endosome, and all this lysosome that surrounds the cell. As you can see in number 4, they kind of attack it, and then they break down the receptor, the lipoprotein, and the enzyme to, they're unusable. And when it does that, the liver cell loses its function because it loses the low density lipoprotein receptor. So it can't get all those lipoprotein that's floating around your blood vessel in huge chunk. And this is really dangerous because, this large amount of bad cholesterol that floats around your body can form plaque, which kind of narrow your blood vessels, and that's not a good thing. So how do you reduce this lipoprotein content? Is that there's a new studies that involve the use of monoclonal antibodies. This is recently introduced by recently new as it's approved by FDA in 2015. They are known as alirocumab and evolocumab. So they help to inhibit PCSK9 enzyme or protein and reduce the lipoprotein A or apolipoprotein B content. The prescription is that you use subcutaneous injection once every 2 weeks. So subcutaneous injection involves the injection in between the skin and the muscle. So it's just below the skin and above the muscle. It's that layer of fat, you can call it, and usually can inject it on your stomach. And this also helps to can use this as an alternative for statin ineffectiveness because people have high tolerance to statins when you consume in large amount. So these monoclonal antibodies, which is marked in blue, they were kind of, I'll just show an example using my hand. So my hand will be the monoclonal antibodies, and this will be the PCSK9. You kind of bind, so it stops binding to the receptor here, and then, this monoclonal antibody and the enzyme will just form their own structure. It inactivates the PCSK9 enzyme, and this lipoprotein that floats around to the receptor will kind of just got onto it, internalized from like endosome, and the release of the lipoprotein from the receptor to the cell, and this lysosome will kind of attack it to break it down to smaller fragments of cholesterol, or if it's small enough, there'll be no fragments of cholesterol that floats around the blood vessel or the blood. So you have done a case study where on 2016, 2017, and 2018, the comparison between statins and the monoclonal antibodies. So the prescription of monoclonal antibodies are about 140 to 150 milligrams for 2 weeks. But then the use of statins use 900 milligrams over the course of 2 weeks. In comparing the result, you can see that the maximum LDL concentration reduced was 60 to 63% for using 140 milligrams of monoclonal antibodies, but it's not applicable to statins. And you can see that low density LDL concentration reached was very minimal. For evolocumab, it was 30. For alirocumab, it was 53, and for the statins, it was 53.7. So by you consume 900 milligrams of drugs over the course of 2 weeks to have about the same concentration as the alirocumab that you consume way so less, and you only consume once every 2 weeks. So you can see the difference of effectiveness that the monoclonal antibodies are really a useful measures as an alternative to statins. So the advantages is that, I've explained earlier, it's an alternative for people who are allergic to lipid-lowering drugs or they cannot tolerate because they have high tolerance to statins and fibrates. The risks associated, such as muscle pain, soreness, they don't really affect your daily life, so you can still kind of meet your friends, do your daily activity, cooking, talking to your friends, going out for coffee. They don't really affect how you move in your daily life. And they also have very reliable testing because these have been, as it's a fairly new product, it has been done by many researchers, journals, published articles, published results. So, you can just go to these science platforms such as ScienceDirect or NCBI or PubMed. You have all the results there for you to refer. However, the disadvantage is that it's really expensive since it's a fairly new technology. So you kind of expect it to be around $5,000 to $10,000 per year. But as far as I know, it's around maybe $7,000 to $8,000 a year. I don't know, but you gotta be somewhere around that range. And I've checked it before. It's really expensive. It's also invasive because you kind of inject it to your body, subcutaneous area. And the side effects is that I've mentioned earlier, muscle pain, soreness, and stuff. And risk associated, there might be unknown cross-reactivity with other drugs. There's a potential, you'll never know. But however, at this moment, since it helps to reduce the low density lipoprotein concentration by a lot, I'd rather that you can use this as a measure, short-term measure to improve the overall well-being of a human. And then if there's anything that cross-reacts with another drugs, we would then reconsider it in the future. So I believe that this monoclonal antibody is a great invention to help humans in reducing low-density lipoprotein content. Thank you.